Time for another Puscast, this one covering the last 2 weeks of August 2013. I'm doing this out of my front porch on a beautiful summer's day, so I'm certain extraneous noise will leak into the podcast. I'm also on call for the 3-day weekend and have been covering my partner for the last week, so I'm a wee bit on the lethargic side. So if I doze off in the middle of this, you'll understand. I'm just like you. Otherwise, the references are available online, and you can visit my website, edgydoc.com, to find my growing multimedia empire. It's a nice stopping point on your way to iTunes to write me glowing reviews. And with that usual nonsense aside, we will move on to the literature. Turnabout is fair play. I like to talk about how South and Central American infections are coming north to the Americas with global warming. There's now been an outbreak of Eastern equine encephalitis in Panama. This is an endemic disease in the United States and also found in other parts of Latin America. Why this has appeared as a problem in Panama was not determined by the researchers. They did not know if it was new importation from the U.S., a change in the ecosystem due to deforestation, or mutations in the virus. But I would like to think it's a cosmic balancing act. If we're going to get dengue, they have to get equine encephalitis. Just so you don't think I'm some sort of hippie goof, I don't think it's a cosmic balancing. But Panama and Central America are popular destinations. I understand there's a canal that goes through that particular country. So it's something to keep an eye on in people returning from Panama. The interesting thing, among many interesting things, infectious diseases, you can go back and look at the impact of infections on history, or the impact of infectious diseases that occurred in history into the present. Boy, that is a convoluted sentence. But this study looked at outcomes of patients who had influenza exposure in 1918. That was an H1N1. And what happened to old age mortality. And they compared a group of patients who were exposed to influenza with a group of patients born shortly before and after who did not get exposed to the pandemic. And interestingly, they found that patients who had exposure to influenza had increased risk for non-cancer deaths as they got older. They also had a decreased risk of cancer deaths. I don't know what to make of this. It's certainly possible that if you got influenza early in life, that it set up cardiovascular disease and that this affected you later in life. I always have difficulty in comprehending epidemiologic studies, but it seems like it was done by reasonable methods to me. So it would appear that the effects long-term of getting influenza young may be real. And this is not entirely unexpected. There have been multiple studies to show that influenza causes vascular disease, i.e. acute myocardial infarctions, and that being vaccinated decreases your risk for getting a myocardial infarction. Yet another study was published out of Australia and reported at the Canadian Cardiovascular Congress that showed that those who had the flu vaccine were 2 times less likely to have a myocardial infarction than those who didn't get the flu vaccine. This is one of many studies to show that influenza is protective for cardiovascular disease. And is one of the many pleomorphic effects of getting vaccinated against influenza. I have a bunch of travel coming up this fall, and airplanes are a good place to get infectious diseases. I've always avoided getting infection by taking a deep breath before I go on the airplane and then holding it for the entire flight. This was a study that looked at how efficacious wearing a face mask was on an airplane flight from New York to Hong Kong. And of the patients who wore masks for the entire flight, nobody acquired influenza from a coughing source in the airplane, whereas 47% of those who did not wear a mask on the airplane got influenza. Hospital rooms are not unlike airplanes, and the food's just as good. So this could be some indirect evidence that wearing a mask in the hospital setting might be beneficial as well for preventing spread of influenza. This is not published yet, but reported over at Medscape. And I should mention, of course, that I am a paid Medscape blogger. But this looked at Fluzone's efficacy in the elderly. And according to the report in Medscape, quote, the high-dose vaccine was 24.2% more effective in preventing influenza in adults 65 years of age and older. So the high-dose vaccine appears to be better at preventing flu in the elderly in this particular study, although the details of definition of flu are not mentioned, and it is preliminary information that has yet to undergo scrutiny. On the other hand, is probably true. When it comes to antigens, more may indeed be better for some infections. Anybody who listens to my podcasts knows that I'm a fan of all things Oregon. The Great Pacific Northwest is the best place to live, period. But it's not all Guns N' Roses or some other non-Axl Rose, including metaphor for perfection. For one, Oregonians are distinctly unstylish. No such thing as a Portlander who dresses and looks good. We are remarkably ugly at style in this state for the most part. And the other is, I'm proud to say, he says sarcastically, that we lead the nation in unvaccinated at 6.7%. When you combine that with the 3 or 5% of vaccines that don't take, we're probably over 10% unvaccinated in school-aged children. So we're primed for some outbreak or another, like measles or, say, mumps. I've seen a case of mumps. I've never seen a case of measles. This study out of Emerging Infectious Diseases addressed the issue as to whether it was of benefit to give a third MMR to people exposed to mumps in an outbreak on the East Coast. Now, everybody who got a shot had already had 2 vaccines, and they were given a third. Those who were eligible had 0% mumps rate. Those who did not get it had a 5.2% mumps rate, which was not statistically significant. But since I expect a measles or a mumps outbreak here in Portland in the near future, I'll put that in my back pocket for something to consider for a post-exposure prophylaxis. Last week I mentioned that the beta coronavirus that's causing the respiratory syndrome in predominantly the Mideast, but as well as some in Europe, has been found in camels. They've also now found it in bats. So they're still working out the source of this particular coronavirus. The bats were probably the source of the Chinese version of SARS from a while back. Whether bats or camels or both are important and spread to human is still being sorted out. I find it interesting watching how new infections are investigated both epidemiologically and biochemically to figure out how these things sneak into human beings to cause disease. Somehow I never thought of being a fisherman as a risk for HIV. I just mentioned this, that a study looked at the, quote, a meta-analysis and systematic review of HIV risk factor among fishermen. And it turned out that fishermen have a 30% prevalence of HIV. Being a fisherman is being as risky as a female sex worker, a truck driver, military personnel, and prisoners. Boy, there's a group of people that I would not have bet had similar characteristics. It turns out, though, that fishermen frequently engage in, as they call it, transactional sex, They don't use condoms. And not only do they mess around while they're out fishing, they then bring it home to their partner and don't use condoms. So fishermen, it turns out, are a big risk for HIV. I don't think this includes my relatives who like to sit on a small boat out in Minnesota lakes going after sun perch. And so I guess it's true that semen is a risk for HIV. God, that was awful, but I couldn't resist. One always frets about giving vaccines to patients with immunologic issues. This study looked at the safety and efficacy of the HPV vaccine in people with HIV. They were all virally suppressed for the most part, and virtually all of them had CD4 counts greater than 200. And all of them had a good immunologic response, and only one patient had an adverse effect, which was fatigue. So it would appear that in that patients with HIV can safely get the HPV vaccine. Given the rates with which that organism causes cancers in patients who are immunologically suppressed like HIV, it's probably a good idea to get them all vaccinated. I always like, as you know, the history that's associated with infectious diseases. There's a great historical review in Emerging Infectious Diseases about plague in Sardinia in the 1500s. And there was a physician at the time, Quinto Tiberio Angilero, who had the title of Morber, M-O-R-B-E-R. This was the person in charge of controlling plague. And this gentleman was very effective at controlling plague on the island of Sardinia. And he did a couple interesting things to prevent the spread of disease. One is he isolated people who were infected or suspected of having plague. The second is that they buried everybody at a distance from the outbreaks, and they were buried by people who had survived prior plagues. They burned all the mattresses, etc., in any house that a plague occurred in. Sounds like they were dealing with MRSA. And finally, for clothes and the like, they applied hot, dry heat as opposed to cold, dry heat. They applied dry heat to the clothing, etc., to basically sterilize them and eliminate both the plague bacillus and the flea that spreads it. And as a consequence, they did a very good job of controlling the outbreak of plague in Sardinia in the 1500s. He had all the right ideas. He did them on the basis of the wrong theories, miasmas and the like as a cause of plague, but it was effective nonetheless. And I think when my contract comes up for review and renewal with Legacy Health, I want to change from chairman of infectious diseases to Morber. It just sounds so much more cooler. I did not know this. I'll quote from the introduction. Before the advent of pasteurization and adequate refrigeration, foodborne transmission of group A Streptococcus pharyngitis was common, particularly associated with raw milk consumption. I did not know that. And they describe an outbreak of group A strep pharyngitis at a high school dance team banquet in Minnesota, where everyone got it from the pasta. It was a home-prepared pasta. I've been to many a Minnesota banquet. My in-laws are in Minnesota, so I know what that pasta was all about. That was the source and furthers my contention that all food should be eaten only after it's deep-fried. A study on the outcomes of hematogenous MRSA osteomyelitis of the spine. The important thing, I think, from this article is that duration of therapy made a big difference in relapse. If you had 4 to 6 weeks, you had a 42% relapse rate. If you had 6 to 8 weeks, you had a 25% relapse rate. But if you had 8 weeks or more, you had a 5.6 relapse rate. It's also important that you should keep the trough greater than 15 in this study, But it's interesting that I usually give my osteomyelitis of the spine 6 weeks of vancomycin, although it's rare not to give them 3 to 6 months of follow-up oral therapy out of paranoia on my part. I don't think I have a 25% relapse rate, maybe because of that. But if you're only going to give IV therapy, it looks like 8 weeks at least is the duration to go on the basis of this study. If there is an impossibility in infectious diseases, it's in determining whether or not a coagulase negative staph in the blood is clinically significant or not. No, wait, there's an article. Scandinavian Journal of Infectious Diseases. When is coagulase negative Staphylococcus bacteremia clinically significant? Question mark? And they went back and they looked at a bunch of patients who had coag neg in their blood, trying to determine what was predicting of it being clinically significant, i.e. the real deal. Well, time to positivity popped up yet again. This time it's less than 16 hours. If it was Staph epidermidis, and they don't usually speciate in my lab, if there's a central venous catheter, if they were from different sets, and if they had a Charleston score greater than 3. And I'm not going to look up what a Charleston score is. I assume it has something to do with a dance from the Golden Age. And they came up with another algorithm for determining whether or not the coag-negative staph is the real deal or not. They gave a positive predictive value of a whopping 83%, which isn't great. Still, time to positivity and having it grow from different blood culture sets are important characteristics in staph epibacteremia that help you determine whether or not you need to worry about it. Almost always you can ignore the 1 out of 2 at 48 hours. There is a tendency to give daptomycin in higher doses than the 6 milligrams per kilogram for which it was initially approved. 8 and even 10 milligrams per kilogram seem to be de rigueur for, don't you love that French accent, for serious infections. There were 2 articles published this month, one looking at the outcomes of enterococcal infections in patients who received high-dose daptomycin, 8 milligrams per kilogram per day, and they had a 90% success rate. The other was patients with left-sided endocarditis and right-sided endocarditis, often due to MRSA, and they had a 90% cure rate using 8 to 10 milligrams per kilogram per day. They actually used 9.8 was the average for left-sided and 9.3 for right-sided, suggesting that they were giving 10 milligrams per kilogram more often than they were 8 milligrams per kilogram for endocarditis. But that's pretty good outcomes for both. So if you're going to be treating endocarditis or enterococcal disease in patients with daptomycin, think about higher doses like 8. And for left-sided disease, I'd probably go with even 10 milligrams per kilogram per day. In my role as Morber of Legacy Health, see, nice callback there, I worry a lot about surgical wound infections and seem to spend an inordinate amount of time fretting over surgical wound infections and their prevention. A recent study suggests that timing of antibiotics makes a difference, and it was the unpleasant number of 18 minutes before incision was the optimal time. I don't think it's going to be possible to hit that number with anybody. Getting within an hour has been logistically interesting. To time it within 18 minutes will be quite the challenge, but that's where they got the best results for their surgical wound infections. The other, of course, is an ounce of prevention is worth a pound of cure, or as I learned it, an ounce of perversion is worth a pound of pure. But this was a meta-analysis in the BMJ on the effect of decolonization and prophylaxis to decrease infections. And they found that in patients who had MRSA, who received decolonization and a glycopeptide, that they had a decrease in their surgical infections due to gram-positive bacteremia. The only thing I would say is that when we have MRSA patients in our populations that get decolonized, we give them vancomycin and cefazolin. The pharmacist always insists on cefazolin, but I prefer cefazolin because there is some data to suggest that vancomycin is suboptimal for preventing MSSA infections. And go ahead and try and get vancomycin in 18 minutes before the incision. Ain't gonna happen. I know I'm supposed to be non-judgmental, as a physician, but some infections are associated with doing stupid things. There was yet another outbreak of Campylobacter associated with drinking raw milk. Seriously, pasteurization is one of the great inventions of mankind. And always remember the gravity well. At the top of the gravity well, cow's butt. At the bottom of the gravity well is the cow's udder. Poo goes from the top of the gravity well to the bottom of the gravity well, taking Campylobacter along with it. There's also this alternative therapy called mesotherapy, where basically they inject into the skin mixtures of materials in an attempt to cure various and sundry diseases. I have written about mesotherapy over at Science-Based Medicine and have a Quackcast on it. There was an outbreak in Australia of patients who got an M. chelotii infections from mesotherapy. I like what they say in the article. Tighter regulations of alternative therapy practices are needed. No, people need to quit doing dumbass things not based in reality. You can't legislate stupidity. But this is not the first and only time patients have had an outbreak of atypical mycobacterium associated with this particular wackaloon intervention. Not that I have an opinion. And I don't know, I think the English and the Australians come up with better words than we do. Whinge for complain and wackaloon for crazies. I like both of them. I like to whinge about wackaloons. But as best I can determine, the average alternative provider has as much understanding of infectious diseases and sterile technique as a cow does of quantum mechanics. Actually, the cow probably knows more. So there was a recent large outbreak of blastomycosis in Wisconsin. What was unique about this was that it was primarily in a Hmong population, which are from Southeast Asia, and included kids who were born in this country and grew up here. So it is uncertain if there is a predilection in that group for developing symptomatic blastomycosis. They could not come up with a specific immunodeficiency. Alternatively, they could not come up with a unique environmental exposure. And it was suggested that this may be a group that has increased risk for blastomycosis, just like there are some who have an increased risk for coccidioidomycosis. There's a nice review on nodding syndrome in Emerging Infectious Diseases. Nodding syndrome is a type of seizure that's endemic in sub-Saharan Africa, where people nod all the time, and they have abnormal EEGs, and no one is exactly certain what causes nodding syndrome. They've looked extensively for an etiology and not found one. Although there is an association with onychosarcoidosis, it's not well described, as they call it a consistent enigmatic association with onchocerciasis, detected by skin snip or serology. So, nodding syndrome is an as of yet unexplained epidemic form of epilepsy. And why do I think it's going to show up in my boards? Now, if you think your life is bad, these people decided they'd figure out what the microbiome of the armpit is. Yes, I know. Actually, that's the kind of thing we need to know. And they found that the armpit was mostly consisted of staph epidermidis species, predominantly females, and Corynebacterium, predominantly males. They can find up to like 120 different organisms, however, by using molecular techniques in the armpit. And they did find that deodorant usage does influence the species diversity in the axillary microbiome. It also prevents you from smelling badly. And this article in the New England Journal of Medicine looked at the risk of fluconazole during pregnancy and subsequent birth defects. They looked for a wide number of birth defects and could not find any except for one. And there was an increased risk of tetralogy of Fallot in patients who are on fluconazole while pregnant compared to those who were not on fluconazole. So they looked for 15 different birth defects, but the only one they could find was tetralogy of Fallot with the use of fluconazole during pregnancy. And I think we'll call it quits. I've gone through all the articles of interest, at least to me, and hopefully to you. So this has been another Puscast covering the last 2 weeks of August 2013, done outside on my front porch, so you can hear the occasional car go by, the occasional frog, and always somebody's using a gas-powered motor to power something. Otherwise, go online and give me great reviews on iTunes. You know my fragile ego demands it of you. The references for these articles are available on my website, edgydoc.com. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you, except I can't figure out anything reading Epic, so who knows what's really going on with the patient. Thank you. In dictation. Goodbye.